So we will be missing some people in the beginning, but I think that's fine, and they can join the conversation as we proceed. It's really nice to. And I think we're very lucky actually that we have such a great collective of experts to discuss with us the subject of preventive therapies for malaria today. And our experts need no introduction, if you like. If there is any one of them who needs introduction, then we can do so. But we do not believe that our experts need any introduction. We're very lucky to have the team here. And today we will discuss the science, the practice, and policies relevant to malaria chemoprevention. And we have a special arrangement today. We are partnering with the Tanzania National Malaria Control Program, who are very interested in the subject of chemoprevention as well as a strategy going forward. And they have been doing some trials in Tanzania in the past few years. And today they would love to share some of those results with us, so that we can use them as learnings going forward. We will discuss those results. We will also discuss the opinions of the Tanzanian NMCP and their plans, and we will discuss the global perspective as well. So we will focus a lot on the technical detail, the science, the practice, and the policies relevant to chemoprevention, and tie that in with the lessons from Tanzania. With us from Tanzania is Abdallah Musasi, who is going to make, at some point in the early stages of this masterclass today, will make some introductory presentation with the data from Tanzania that will then be discussed. But in addition to that, we would like to really tie in as much as possible with the global perspective. I think, Nana, what would really be nice to begin with is if we can ask maybe David, if that's okay with you, if we can ask you in the beginning to very briefly just explain what these preventive therapies actually are. Like in like the most basic form, we have 6 versions of malaria chemoprevention that are approved by WHO. And if you don't mind, if you could just explain what these are in lay language in the beginning. David, please.
Okay, thank you very much, Fredros, and good morning and good afternoon, everybody. I know Fredros thought that introductions weren't necessary, but maybe I could just start. So my name's David Schellenberg. I'm currently based at the London School of Hygiene and Tropical Medicine. But actually, I returned to the London School in May, having spent 5 years at WHO, where I was involved in the guideline development process. And before that, just by way of background, I was also based at the London School for about 10 years. And before that, I spent about 10 years living and working in Tanzania. So I started in Tanzania, I guess, in the mid-90s, where we were in a really sorry state in terms of the global malaria situation. Huge numbers of cases and deaths, and a real lack of attention and investment in malaria control. And at that time, insecticide-treated nets were just starting to creep in. There were some encouraging results from West Africa. And actually, some of the first results in terms of the effect of insecticide-treated nets were generated in a study which also evaluated chemoprevention, or chemoprophylaxis to be more accurate, where children were given subtherapeutic doses of a malaria drug during the rainy seasons in that very seasonal transmission setting in the Gambia. And that study showed very convincingly that chemoprophylaxis was able to not only prevent malaria and severe malaria, but also prevent death, as you would expect. A really strong, striking finding. And it's always been a little bit of a puzzle to me that actually then, following that study, attention really switched to insecticide-treated mosquito nets. And we've seen huge investments and massive progress in malaria control, largely as a result of the investments in mosquito nets. And we've seen a relative neglect of the potential of drugs to prevent malaria in people living in malaria endemic settings. And I think there are some good reasons why vector control was prioritised. Concerns about the cost of large-scale, long-term chemo prevention or chemoprophylaxis. The cost, the acceptability, the feasibility of accessing large numbers of people on a regular basis for prolonged periods of time, the acceptability of that sort of approach. I'm not sure how many of us would be happy to take maybe weekly or perhaps just monthly treatment doses of a malaria medicine to protect us for what, years. Concerns about drug resistance, concerns about interference with the development of naturally acquired immunity. So chemoprophylaxis or chemoprophylaxis was put on a back burner for a good number of years. But there were people who thought, well, hang on, these protective effects are really so marked. Might it be possible to kind of reduce some of the concerns around the long-term use of drugs for prevention by not aiming to give chemoprophylaxis, but to give intermittent treatment, intermittent preventive treatment? And this was first formally evaluated in pregnancy, and what we now know as IPTP, intermittent preventive treatment in pregnancy. Early studies in Malawi, followed by a randomized controlled trial in Kenya, and very rapid adoption by WHO of a recommendation in favor of intermittent preventive treatment in pregnancy. And the essence of that and all chemo prevention strategies is that treatment dose of an antimalarial is given at a scheduled contact with somebody, regardless of whether or not they've actually got malaria. And the idea is really simple. If they happen to have malaria parasites, then the treatment will get rid of them. But rather more importantly, once they've had the treatment, they should be protected from new infections for a period of time. So initially, 3 doses of IPTP were recommended during the course of pregnancy in the 2nd and 3rd trimesters. And then within a few years, it was proved that actually 3 doses is better than 2. Not a great surprise there. And then more recently, a few years ago now, when there was a recommendation for women to go to antenatal clinic on a monthly basis throughout pregnancy, the recommendation was then that they should be offered IPTP at every visit to the antenatal clinic, so at monthly intervals during the 2nd and 3rd trimesters of pregnancy. As that whole story has been developing, then in parallel there was interest to explore the use of drugs, intermittent preventive treatment in young children, recognizing that they are the people who unfortunately bear the brunt of severe malaria and malaria deaths. So when I was in Tanzania, I was privileged to be able to work on some of these studies, looking at children below the age of 1 year, who at that time carried over half of the malaria deaths in the hospital setting. So a highly burdened group of children. And the approach we used was to give them treatment doses of SP, sulfadoxine pyrimethamine, when they came for some of their routine vaccinations. So making use of existing contacts with the health system, give them a treatment dose of antimalarial, and see what happens. And we found that that reduced malaria in the first year of life by about 30%. And it reduced hospital admissions with malaria. It reduced severe malaria, and so that, one thing led to another. A number of studies were done in a range of different settings, and that then was also recommended by WHO. Recommended back in, I think, 2008, but hardly implemented. I think Sierra Leone was the only country to adopt it, and we could talk more about that. At pretty much the same time, colleagues in Senegal, Jean-Louis, who is also on the call, and colleagues were working on the use of chemo prevention in intensely seasonal transmission settings. So this is what then became seasonal malaria chemo prevention. And many of you, I'm sure, are familiar that now I think the estimates from WHO published last week were that 45 million children received one or more SMC doses in 2021. So that is a very widely implemented and successful strategy, not without its problems, and I'm sure we'll come to some of those. Then in the recent update to the WHO guidelines, it was published in June of this year, 3 new strategies were recommended for the first time. One is intermittent preventive treatment in school children, recognizing that actually malaria is a common cause of absenteeism from school, and there is evidence that intermittent treatment in school children can help to protect them from infection and the consequences of infection. Another new strategy was this post-discharge malaria chemo prevention, PDMC. And this is targeting children who've been admitted to hospital with severe anemia, and recognizes that these children are at surprisingly very high risk of severe disease, readmission and death in the 3 to 6 months following discharge from hospital. And there's evidence that if you give them intermittent preventive treatment, you can reduce mortality and severe disease and readmission. And then finally, mass drug administration was included in the WHO updated guidelines. And there are 2 sort of main use cases for mass drug administration. One is to reduce malaria transmission, but the other is also to reduce disease. And this is a relatively complicated area, perhaps because it's been used, of all the strategies, it's probably been used the longest, but usually to reduce transmission with a view to reducing transmission. But the WHO does now recommend that in some situations, MDA could be considered to reduce disease burden and death. So I don't know, Fredros, have I talked already for too long? You have to tell me what I should be doing.
Fantastic overview of the masterclass for today, David. I think that what we wanted to do was to have this introduction, and then we're going to invite our colleagues from Tanzania, and it's nice to have this introduction, because then when we do get to see the results from Tanzania, that people are already conversant with the different forms of chemo prevention. So we will, we have 1 or 2 questions for the panel members, and then we will invite Abdallah to discuss that. But you didn't go too far. You did an excellent job, and thank you so much for that. Yes, Nana, you pick it up from.
Yeah, thank you very much, David. I think it was a very good setting for all the different strategies. Particularly, I think the PDMC might be new to many people, perhaps. Now, on this slide that we have here, you touched a little bit on it, but if you can tell us a little bit about why the hesitancy, knowing the benefits of these chemo prevention strategies, what happened, why did it take so long to get these implemented?
So I'm just looking at the slide here. I don't know if everybody knows, but the strict instructions to the panel, Umberto, Corinne, Jean-Louis, Dorothy and me, was don't prepare anything, just come along and have a chat. I think if you ask 10 different people why the hesitancy, why did it take so long, or why is it taking so long, you'll probably get 10 answers, and they'll probably all be valid. I think that there was an aspect where the malaria community as a whole was a bit diverted by this exciting development and the recognition and the hard evidence that insecticide-treated mosquito nets save lives. And so rightly, there was a huge amount of effort focused on developing vector control approaches. And this all started at a time before the Global Fund, before the President's Malaria Initiative, where investment in malaria control around the turn of the millennium, year 2000, I think the total global spend on malaria control was about $100 million, which is, you know, peanuts in comparison to what we know is required. And I always reflect slightly sadly that that's the $100 million spent on malaria was about the same as the budget for making the film the Titanic, which I think is a bit of an indictment on the priorities of people, and nobody in particular. But anyway, but then when it actually comes to chemo prevention, I think I mentioned already kind of challenges around the cost of the drugs themselves. Although the drugs that have always been used for chemo prevention are not the most recently produced, they're not the most expensive, but still, if you're giving large numbers of people multiple doses of treatments, those costs add up. Then you've got the costs of delivering them, and when it's chemo prophylaxis requiring maybe weekly or monthly doses, you need a system to deliver those. I guess the beauty with IPTP and what was IPTI, intermittent preventive treatment in infants, was that they made use of existing contacts in antenatal clinics and with vaccination clinics. So those costs should have been really well contained. Then I guess, you know, question concerns and maybe beliefs in terms of the donor community, malaria control programs. To what extent would the target recipients be willing to accept, and would they be compliant with long-term chemo prophylaxis or chemo prevention? What we see up there on this slide, drug resistance and impairment of immunity. I touched on those briefly, but I think it stands to reason everybody would expect that if you use a lot of a medicine, whatever the medicine is being targeted at will do all that it can to evade the weapon that's being used against it. So it's kind of inevitable that resistance will develop. And so there was concern that if you've only got a few drugs and you're using the same drugs for prevention and treatment, we don't want to jeopardize or compromise your treatments because you're giving lots of prophylaxis to people. And I think that has been a major concern, but that's a concern which I think has been ameliorated in recent years. And I think the reason that we're less concerned about drug resistance now is, on the one hand, that there's evidence that the effect of intermittent preventive treatments on the spread of resistance is probably much less marked than we had previously feared. So intermittent treatments seem not to induce wild, rapid spread of drug-resistant parasites. That's the first point. The second point is that actually, even when using these older drugs for chemo prevention, they seem to work surprisingly well, even in situations where there's quite a lot of resistance. I think, Fredros, you were encouraging me not to get too technical too quick, so we can come back to this point.
We will definitely come back to the questions of. I mean, it's nice that you raised them, though. I mean, people always ask, why did it take WHO or other partners so long to propose chemo prevention as a widespread use? And I think that the point you raised are super important here. One thing that has surprised me is the fact that there used to be only $100 million budget annual for malaria. You're asking people to buy these expensive medicines for people who are not sick. It probably makes a lot of sense. But you're right, we will come back to that, depending on also with Nana. But we will come back to these questions of immunity and drug resistance, etc., etc. So don't worry about that.
Okay.
Yeah, back to you, Nana.
Yep. So thank you very much. Frederick, do you want us to continue here or with the...
or maybe we can now invite our Tanzanian colleagues.
Tanzanian, yep, I think
now we have a good background.
We can get them to tell us
topic.
about their experience. Yep.
Yes, and so again, just for our audience, we have a very special masterclass today. It's a joint masterclass between global experts and our NMCP directors. We are lucky to have the team from the Tanzania National Malaria Control Program, and they are very, very interested in the question of chemo prevention here, and we are inviting them to provide an overview of the studies that they've been doing in Tanzania. And then we will all discuss that. So Abdallah, if that's okay with you, you can share your slides. And he's going to talk for about 10-15 minutes, and then I would like us to have this conversation together with all our experts and our Tanzanian partners. So Abdallah, is that fine?
Hello, yeah, good afternoon, good morning to some others. Dr. Lusasi from National Malaria Control Program. I think my colleague has been joined. I have 3 people who are researchers. The PIs from Ifakara, as I have said, from Muasi, and the Nimri Tanga. These are people who has been conducting operational research of the issue which we are going to discuss. My presentation layout is, I will talk about guiding principle and the technical guidance, introduction to malaria preventive therapies, intermittent preventive treatment of school children, perennial malaria chemo prevention, as formerly was IPTI, the seasonal malaria chemo prevention, post-discharge malaria chemo prevention, and the massive drug administrations. Thank you. Yes. Yeah, the National Malaria Control Program has introduced the tailoring intervention for supplementary malaria strategic plan of 2018. The aim is to address the reduction of disease burden in moderate and high transmission, and again, specific intervention targeted disease elimination in very low and low transmission area. If you see the right side, the left side is a map of Tanzania with the strata, the red color, blue, green, like that one. That is the stratification. But again, we tried to target the intervention according to the transmission. As you see the red color, since 2018, we had these intervention like SMC, IPTI, IPTP, and IPT score. But malaria control strategy shifted from one size fits all to the target approach according to malaria transmission. Again, in 2021, the information has been taken from 2018. Now, the 2021, you see the strategic plan. Again, you see the map. Those colors is intervention targeted. So if you see the northern west is a bit purple, and the southern east is a purple, this area is high transmission. It's the area where we are thinking, we are targeting to initiate this new preventive therapy, IPT school, SMC, IPTI. And some of the intervention is a class-based, is a cross-cutting, like net distribution, use of ICT. In the some area, we provide IPTP and MRDT testing. These are mostly cross-cutting interventions. This one is a current treatment guideline, which also highlighted this intervention. But in some area with some modification, for instance, withdrawing IPTP in very low transmission risk, these are area where we are running now CBS community-based surveillance. We are conducting elimination interventions, encouraging IPT school, IPTI, SMC in high transmission risk, and then introducing post-discharge malaria prevention. This is everywhere, and the introduction of focal MDA. Again, this one is a primary target. You see the infant targeted for RCH. These have been given the preventive medicine during the Penta 2, Penta 3, and MR 1. Again, primary school, you see IPT school in high and moderate transmission is a targeted area. The SMC 3 month to 59 month only, these are targeted global, and it is under the moderate and the high transmission. And again, the post-discharge chemo prevention, again, is for children who are discharged with severe malaria and severe anemia, but those from moderate and high transmission. Intermittent preventive treatment for children. As I've said before, this one has been conducted by National Institute of Medical Research, Tanga. The PIZ joined me in our Zoom. But this one, according to the WHO, June 2022, the school-age children living malaria endemic setting with moderate to high perennial seasonal transmission can be given full therapeutic course of anti-malaria medicine at a specific time. IPT school, now this is a result from our colleague. The intervention was conducted from 2020 to 2021 May in Kilindi Handeni, DC, in Tanga region. Again, CCTPH and NMCP have been conducted the same intervention, but in another area through implementation pilots. And namely, it has been covered in 127 primary school with 73,000 school children. We have been using the medicine, the DP. The result is the IPT school attributed to 80% reduction of malaria parasitic and had a protective effect of 41 clinical malaria. It was shown that the IPT school delivery through school teacher 3 times per year was feasible in the cost benefit. This one is a programmatic issue. Yeah. Yes. Again, sorry, I came back again. The IPT school delivery can be done at the same time with the NTD medicine. The NTD providing anti-helminthic systematicis. Yes, if you do together, it brings some values. This one is IPT school programmatic framework. This is an option which we tried to customize from WHO guideline and what we have been using. For instance, drug option, SP amodiaquine, amodiaquine, and DP. And then the risk group we have shown there, the school age 5 to 16 years, and the out of school frequency, how many we provide this medicine, 2 times, 3 times, 4 times, and the eligible cancels. IPT school programmatic target. We say that we are thinking to conduct it in high and moderate transmission. Now, in high and moderate transmission, we have a unimodal and bimodal cancers. So these are coming from high transmission, for instance, 49 cancel and the 15 cancel. If you add it, it's 64 cancel. These are eligible area to be conducted in this IPT school. It's almost 26% of the cancel. But again, we should go through the public and the private school with a different percentage targeted. For instance, 28.5% with the public school and the private 11.1%. The IPT school population target is a number of public schools in a unimodal. It's not a bimodal, unimodal only. The targeted is percentage 13.97, the targeted, and the bimodal is 11.3%. The total is 41.92%. This one is a molecule, it's a drug which we think it to be used in future, but with a different cost. if you provide in 3 administration, it is seen there in the left side, the cost it differ with the 4 rounds. So according to the WHO recommendation, you might provide the 4 rounds, and we think to do so if possible in the future. Intermittent preventive treatment for IPTI or perennial malaria prevention. This was conducted by Pakana at the Institute. And what is it? According to the WHO, perennial malaria prevention is an area with moderate to high transmission of perennial malaria transmission. Children belong to the age group at a high risk of severe malaria can be given anti-malarial medicine at a predefined interval to reduce the disease burden. Previously, it was referred as IPTI, but now it went to PMC. We provided this drug together with our research institution, Unipeta 2-3, the MR1. I think they are going to talk much on this. Again, the IPTI, the result is this one. The NMCP commissioner IHI to conduct the intervention from March 21 to February 2022. The target age was under 1 year during Penta 2, Penta 3, and the Mwara 1. We did the Nachingwea Council in the Ruangwa, and the Liwale was the control arm. The medicine used was 2 arm, the SP used in Nachingwea, the DP used in Ruangwa. The result was protective efficacy was 76%, but the control site had a reduction in malaria prevalence by 80%. These one are molecules, these are drug assumption we think to use in the future, the SP amodiaquin DP. But again, we have the line in framework, the drug option, the risky group, the frequency, and the eligible cancers. IPTI programmatic target, as I have said before, the Penta 2, 3, and the MR 1. But again, we think in option 2 to go to MR 2 as possible, parallel to the schedule of vaccination in EPI services. This one is the IPTI programmatic issue option. For instance, this is a cost of medicine. The DP, you see $3.260, but the lowest is SP 0.18, which we have been using it. And again, they are, okay, thank you. Seasonal malaria chemo prevention, SMC, conducted by Mwembe University of Allied Science and Health Science. This is a MUAS. The PIs, I think, has been joined again. The SMC, according to WHO guideline, June 22, in the area of the seasonal malaria transmission, children belong to age group at a high risk of severe malaria should be given anti-malaria medicine during the peak season. The malaria transmission season to reduce it, this one, okay, the aim is to reduce the disease burden. The results of SMC. The period, it was conducted in March and June 2021. The target age was 3 to 59 months. It was in Nanyumbu in Masasi district, Twara, but the medicine was a DP being used. Generally, overall prevalence declined by 54%. This one is a medicine, it's a drug, which in a program we think in the future to use it. SP, amodiaquin, atosines amodiaquin, DP, but again, the drug option, the risk group frequency, and the eligible cancel to be conducted. This one is the map. The step 1 is showing an area with the more than 60% rainfall in 3 months. This is trend of rainfall. And then the second step, this one is more than 60% cases, means falling after rainfall. Now the cases you get more than 60% per month. And then the third one, this one we mixed it at the sea, the area which is the region in our country. We have highlighted some area which are having more than 60% rainfall and the cases more than 60%. Moderate and high transmission again. Okay, this one is a programmatic target. Again, we say under 3 to 59 months of age, as we've done in this group, it is 4.8, the eligible group. And then if you go according to the WHO now recommendation, up to 10 years, we might get the 4.81 percentage of this age. Again, the medicine, the molecule to be used in future, the DP, the ASAC, the amodiapinesp, the cost it differ from one another, and it differ from one round to another round. If you do 3 rounds and 4 rounds, it differ. Post-discharge malaria chemoprevention. Okay, this one is the children admitted to hospital with severe anemia, living in setting with high malaria transmission, should be given full therapeutic course of an anti-malaria medicine to prevent the death and the readmission. PDMC, post-discharge malaria chemoprevention, again from a programmatic issue. At the country level, additional medicine to be procured within routine medicine allocation, because now we think to use this PDMC, we should have more medicine. The health facility admitting patient to use the same logistic for further malaria quantities to be determined where prophylactic medicine should be dispensed, thinking of nearby health facility. Needed to orient council and health facility staff, set up appropriate information system. MDA, master drug administration, this one is a burden targeted for burden reduction, and to provide a short-term reduction in disease burden. Again, MDA burden reduction in emergency situation, the emergency or period for health services disruption. Again, it provides a short-term reduction in burden of disease. MDA to reduce transmission in very low transmission setting. Again, in area with very low and low transmission, malaria medicine can be given to chemoprevention through massive drug administration to reduce transmission. MDA only a planned option for MDA introduction according to our strategic plan. It's a part of CBS community-based surveillance response. Case-based surveillance, the response to clear transmission for site in very low transmission. We have 5 regions we are running, which we are conducting this intervention under elimination platform. The ECT and the PQ to be using and administered. The PQ, primarily we are using very low dose, 0.35 milligram together with this ECT. The second option is to introduce MDA as a part of complex emergency management and outbreak response. Way forward, different pharmaceutical option, targeted population, cancer eligibility, and the frequency of administration to be carefully analyzed in order to select the best opportunity to reduce malaria burden. The selected option need to be modeled to forecast the impact of cost benefit. Complete or partial scale up need additional resources. The current are not available. Partial to be included in the coming resource envelope. The request for group funded PM1. Thank you so much for listening.
Thank you very much, Dr. Luciasi, for your succinct presentation. Really good, and it's good to hear the experience from Tanzania. In your very last slide where you talked about the way forward, and during the whole presentation, some questions were coming to me. Like one, what was the acceptability from the community? Can you tell us a little bit about that?
Okay, thank you so much for the question. The intervention has been conducted, and the results has been released as I have said. But for this, I want to send this question to the peers who are around it. But I don't know acceptability to which intervention. The intervention was 3. The operational research was 3. The SMC, IPTI, and the IPT score. So I don't know. You are asking for which.
Dr. Lisasi, you're breaking up a little bit. I'm not sure if I got the question right. You're asking if which kind of what specifics am I asking about the acceptability? Very general question, really, to see that from the community. How was it? Because this is under study, and because typically SMC and, for example, is done in the Sahel and not in East Africa. So I wanted to find out what the community's acceptability was.
Okay, thank you so much. May I invite Professor Bill from University of Dar es Salaam, Muhimbili University, MUHAS, to respond on this.
Hello, everybody.
Hello.
Yeah, I think the issue of acceptability was assessed, and we have not yet published the findings, but I could say there was high acceptability at the community level. Even at the point when we are leaving the sites, even adults wanted to join the SMC, which was somehow very difficult to add them because of cost. So we have some interesting findings which will be later on published, but the acceptance was very high. Initially, people were scared because the timing of SMC was during the COVID pandemic. So once they saw white cars, they knew people come to vaccinate them. But later on, when they knew it was malaria intervention, it was highly accepted.
Yeah.
So
Thank
we
you.
later on share our findings through publication. We have not yet published their findings. But
Thank
the
you.
acceptability was over 90%.
We will be attentive for this when it comes out through the publication. Then another question I wanted to ask is, what challenges, let's say, did you have with procurement? Because here today we have Corinne as well, and we also have all the experts, and we know that for SMC with the issues of stockouts, general drug administration stockouts, procurement. How were you able to maintain under this study, under the study umbrella and the procurement? How do you envisage that in a real life when this starts to be implemented? Issues with procurement, ensuring that you constantly have enough drugs. You've already mentioned the issue of cost, and it was very interesting how you presented each of the cost and for the different strategies. Can you tell us a little bit about that, how you envisage the program will be managing all the possible challenges that would be possible?
Yeah, I think this is a very good question, because procurement was something which was very hard to estimate at the beginning, because SMC is done at the community level. So you don't go to establish the structures of healthcare. So when we are going to the community level, we found out the medicine we have was not adequate. First of all, on total number of doses, because for us, we are doing a study, not implementing a program. So you estimate the sample size, but it turns out when you go to the community level, you may find there were so many under 5 children. So we had to spend even some money, which was not planned for buying medicine, to buy extra medicine. So it somehow took extra cost, and then partly because DP is expensive compared to artesunate SP, no, to amodiaquine SP, which is somehow cheaper. So it took a chunk of money to buy medicine. So I think the organization of SMC may be very challenging compared to doing a school IPTP, which is somehow you go to schools with the actual number of students, but when you go to the community and also moving in villages, You find that people are widely scattered around. You find the interest of the medicine sometimes goes beyond the age group, because we are targeting under 5 children, but you find even children who are above 5, they wanted medicine. Even adults also, they wanted medicine if the problem is high in the community. So those were things which we need maybe experts to estimate the amount of drugs. And that is something we faced during the conduct of the study.
Yeah, thank you. Yes, certainly. So whilst we were preparing this with Frederick, so supply chain issues, like you've mentioned. And then just one more question to you, and before I go back to the expert, is the do you think, because we've said it again, this is in a study, do you think your system, the health system, is the readiness of your health system for the implementation of this in the community? What would you say?
Yeah, also the readiness of the system, because we delivered medicine by using community health workers, organizing it through the district level, and then the wards. You reach the village level, then to community health workers. So there's some extra there are some extra cost which comes because community health workers are not part of the payroll of the health system. So if you have to add this in the program, you need to find extra money to pay them. We were not paying them much, around $5 to $10, but that one should be a budget if you have to cover the whole district. The good thing for Tanzania, we don't have many areas which may need SNC, but that is strategy will require extra resources because you use a number of people who are not part of the government employees to implement the program.
Thank you. We will go back to that point. The whole issue around community health workers is a very big one and very important one too. So now to the experts. So logistics. So this is one thing that came to us while preparing this is logistics. Who delivers? How will the stockouts be managed and to prevent them from the start? And supply chain issues that we've Billy has also mentioned now. And yep, who will?
It's Nana. Before we push to the expert, I just want to say, really, I mean, just looking at the evidence from Tanzania. So two things: the evidence on the side, but also the actual plan. So the NMCP is presenting, for example, their projected cost for the different medicines, and you just see here quite a well-organized planning. I was listening to this, and all of a sudden I'm feeling like, man, I should do an internship at the NMCP just to see how this operation runs. I imagine, though, that it's a fairly difficult thing to run all the different chemo prevention strategies at scale. And so maybe if the NMCP team can just let us know how they manage to do this and what the plan is for the future. You're planning to do SNC, you're planning to do PDMC, you're planning to do MDA, you have IPTP, IPTI, IPTSC. Operationally, of course, Nana was asking about the health systems situation. Here, see the issue with the stockouts. You see how much will be needed, but how complicated is this? Can you talk a little bit about the operational side of things if you were to go forward with the implementation? So any of the members from the NMCP, and then our experts can chime in as well. Nana, I hope that's not big introduction for you.
No, it's perfect.
Yes, Dr. Lusasi or any of your team members, that would be good. If Lazaro is back.
Okay, thank you so much. I think I'll start with it. My colleague Fabrizio will second. We have a system in place for procurement and the supply chain.
There's a little bit of noise from your end, so I think you have 2 computers active, so maybe you can just go ahead, Dr. Sati. Thank you so much.
Okay, thank you so much. We have the supply chain in place, which we are using, and this supply chain, it is very effective. The medicine coming from medical social department there, going along the channel to the facility through requisition from the facility charges. So we think this, for instance, if it is called, the medicine will be requested by facility according to the number of the student needed, or the students who are going to get this chemoprevention. So we think we are going to use the same channel. And before that, we are going to make a quantification and then a proper budgeting during the global funding request to make sure that these interventions are again, the issue of operational, I think the peers will talk much, but we use the school teachers to dispense it, to dispense the drug to the student. Again, the school teacher have been getting a backup from a facility providers. And then the storage of drug, it has been done in the nearby school. So I think it's, according to the research we did, it's possible. Dr. Faris, please you may add a bit. Sorry.
Okay, go ahead. Dr. Fabrizio, welcome.
Yes. Yes, hi everybody. Welcome. Sorry, we have some echo in the room. Yeah, non lascio commento. Sorry for just a moment.
Okay.
No, yes, sorry. We had some echoes because of the multiple devices used in the room. Now, about logistics, anyway, we are talking about the 3 completely different intervention. Definitely the simple solution is the IPTI that is following completely the health facilities logistics system within the routine logistic information and logistic supply system. The school has been, we had the 2 arms, one in Tanga, it was the more operational research arm, and one in Kigoma that was more an implementation pilot intervention by using the routine services through the health facilities where the medicine were delivered, and through the education system where the intervention was coordinated. So our intervention is showing the feasibility for the 2. The more complex one is the seasonal malaria chemoprevention. But the seasonal malaria chemoprevention, we try to put in place 3 different delivery options. One, by using outreach services from the health facilities. Probably have to make clear that the community health worker system is not very well developed in Tanzania. We are currently trying to discuss for a improved platform to include malaria intervention on the CHW through the community health workers, but is not yet in place. So the best option and the option that has been used is not through community health workers and delivery of the medicine house by house, but it was by setting up village post through the nearest health facility outreach services. So the logistics is an important part, and among the logistics, one of the issue was about the alarming artemisinin resistance markers that have been already identified even in the northwest of Tanzania, close to the Rwanda and Uganda borders, as expected. So it means that we have to be very cautious, and this was one of the several reasons that put on the ground and trying to do calculation based on a different option. Among the different option, we try to put always non-artemisinin options like SP and SP amodiaquine, just to introduce the concept that we may need alternative there. Maybe I can now go back to Eric. There are a few comments from Eric that sure, I mean, is showing concern about the introduction of new intervention in the country that is not performing routine universal coverage as expected. But I don't have a personal position on that. But I mean, it will be for the floor, and especially for the global expert, to discuss about it and to see how can the preventive therapies significantly changing the burden of malaria in areas where there are some bottlenecks in the delivery of the routine healthcare. I believe that I'm over on this. Sorry, and I don't know if I'm right, but the significance of the chemo prevention is not only to contribute to a reduction of morbidity and mortality, but to increase the effectiveness of the intervention. So it may be that the effectiveness of the intervention can be improved by introducing other possible alternatives.
Thank you so much, Fabrizio. Excellent. Nana, back to you. Fabrizio,
yeah. There are some very interesting questions in the chat. I think we should bring on board.
Hello.
Yes, Fabrizio, we can. Okay. So, Fergus, I think there's some very interesting questions in the chat we should bring to the table.
Yes, my suggestion is that we try and bring the experts, the other experts on board as well, if they can contribute to these questions. I think that would be really, really nice.
Yeah.
As we continue with the conversation on both the Tanzania.
We must also highlight this very impressive work and very detailed, succinct presentation. And I think there's much that we can all learn from. And well, let's go ahead and see the other points that we can learn from here. Okay, so.
Right. So how do you want to do that? Shall we take the questions from Tanzania and
yeah,
bring?
Let's take the questions from Tanzania. Yeah.
Excellent. So I'm just going to drive this back to where we began here. David already provided, a fairly nice overview of the history of the process, to the point at which in June 2022 WHO released this comprehensive intervention. So it's of course really nice to see that the Tanzanian NMCP is having this plan to implement so many of this, and the evidence from the trials there was excellent. I mean, some of those reductions of 30-50% in many of these cases, I think was just really, really nice to see hopefully, this is something that can be supported by the global community going forward to make sure that the implementation actually happens. We've talked about the health system structure, and I would like to request, first of all, Dr. Umberto, if this is okay for you, to just, going back to the questions that were asked earlier about the health system requirements here. Here is a slide with health systems for the treatment side. We didn't have any for the chemo prevention side, but in line with the discussion from Tanzania, what do you think are some of the things that the team needs to look at as they make their global fund application next time to get this implemented? What are the key issues that you think they should be looking at?
It's for me, right?
Yes, it's for you.
Okay, thank you. No, first of all, I would like to congratulate the Tanzanian team because their strategy is very articulated, very, I would say, sophisticated, in a way that they actually identify different package of intervention. That's exactly what we need to do, to identify different packages of intervention according to the characteristic of transmission and burden of malaria in a specific area. And it's more easily said than done because it requires the different planning and different training and so on and so forth. So I think it's really a major achievement. I think for their global health global fund application, I think I would say to continue like that, I guess they probably would need, I mean, my personal opinion would be to really insist on surveillance, because once you implement this intervention, if you do it successfully, the situation is bound to change. So and obviously you would like to capture that change with the data collection. And so I think that's something, an aspect that probably should be emphasized into the application and put sufficient resources for that, because everybody is talking about surveillance, but I think surveillance needs some specific resources to be effective. Now, I just wanted to comment on one thing, one or two more comments about what has been said up to now. The first one is about, we are talking about intervention without really talking about the actual treatment, although, the Tanzanian colleagues did, and they showed that they are considering different treatment for different intervention. But, using, for example, SP amodiaquine for SMC is very different from using DP or even Piramax, for example, pyronardine artesunate for SMC. So the characteristic of the drugs are different. And even for the MDA is the same thing. We are talking about treatment, but not all treatment are equal. And so I think there's a need to think about what kind of treatment we want to use for each of the different interventions. Having in mind the main, the essential criterion that treatment used for treating clinical cases should not be used for prevention. But the other point is compliance of treatment, because as you know, except for SP, all the other treatments are 3 days. And I think this, and I saw somewhere in the slides, compliance was mentioned, but to have the target groups or the target individuals taking 3 days of treatment is not an easy thing to do. And I know that people probably, given that sometimes there are stockouts, shortage of drugs, people actually prefer to not take maybe the second or the third day of treatment and keep it at home. And that's something that can drive resistance as well. So I think these are the few elements I wanted to mention. Thank you.
Okay, thanks, Pedros. So here we have on this slide, pregnant woman. We all know very well that the strategy for giving SP, IPTP, was recommended many years back, but unfortunately, this still has very, very low coverage. And can we tap a little bit on why has this been, and what can we do moving forward? Perhaps I ask this question to John Louis.
Yes, thank you. Thank you. Maybe just before I respond to that one, just a comment on what has been already presented by the Tanzanian team, that showing really the leadership of that program, and maybe just to inform them that there's a SMC Alliance groups, which is combining all the 13 SMC countries in the Sahel, which has been successful in implementing SMC programs since now maybe 8 years of experience, and that we could create, I mean, if they can link to those people. We have Andre Chwacha here, and we have also Dorothy Achu, which was really critical in that SMC Alliance group. She can share some best practice to see, for example, about logistics, about estimates of targets, and so that things maybe could link with that. And maybe also for the Global Fund application, I mean, the data will be very important. So probably if they can be supported by some modelers or some groups can help to understand better the data and interpret them, provide good evidence, would support any strategy, any intervention. So for the IPTP, of course.
So Professor Jean, so just sorry for interrupting. So those are two critical points. I just want us to tie this directly to our Tanzanian colleagues' presentation. You are saying that they need to, better organize the data. It looks great, and you are suggesting that it might be helpful to integrate into the SMC Alliance.
Yep, exactly.
Okay,
exactly.
And then I think Professor Umberto was saying that even though the programs are all chemo prevention, the medicines required are different, and that there need to be clarity on the medicines and the uses for each of those going forward. So I think those 2 points are really important, also in consideration with our Tanzanian colleagues. Sorry for interrupting, Eugene, but please go ahead.
Yeah, maybe now raising the question. Nana just said about the IPTP. I mean, definitely IPTP has proven its efficacy in many settings, even in area where SP resistance is very high, meaning that probably there's other benefits than antimalarial provided by the SP. And seems that we all struggling with the IPTP3 or 2 in many countries. I mean, the problem could be the channel. They could be the ANC, the antenatal clinics. So probably we have to look at maybe, first of all, the alternative of the SP, but also a way to improve the coverage. Coverage is still a problem, and there's many experience of IPT, community IPTP in many countries, seeing how we can, like the SMC, how we can really go deeply into the community. It could be through the SMC campaign, it could be through other channels to identify the pregnant women as early as possible and to increase the number of contacts up to the delivery. That's 1 or 2 maybe possible solution. Maybe I'll hand over to Umberto, who is really a specialist to add it. Thank you. Over.
Go ahead, Dr. Umberto. Pick it up.
Sorry.
And I noticed that Dorothy has actually joined as well. So
tell me, what was the question for me?
Dr. Jean was asking you to make any contributions on the question of low coverage of IPTP.
Oh yeah,
even though it's the one that was that's been there for the longest?
Yeah, I think you know, I think it's mainly, my impression is that it's mainly a problem of health system that rather than attendance to the antenatal clinic. If the treatment is available at antenatal clinic, women usually are given the treatment. So I suspect that a lot of where there is low coverage, I suspect it depends mainly on stockouts, rather than women not wanting to take the drug. I know that something like 20 years ago or more, in some countries there was resistance from the health staff to give SP to pregnant women. But I think that issue has been solved nowadays, I think. So it's really, I think, a problem of the health system and of logistic and distribution of the drug.
Yeah, may I add also that probably a lot of pregnancies in our African context, you know, frequently women sometimes they didn't know they are pregnant, or they don't want people to know that they are pregnant for a while before starting to go to the antenatal clinics. That's meaning that the number of contacts will be also reduced, and it could be, I mean, there's probably several factors. There's stockouts, there's a health system, but it could be a lot of factors combined that can explain it. Thank you.
That's excellent. Go ahead, Nana.
Yeah, there are some hands. Fabrizio, maybe Fabrizio, can you go? I'm sure you want to.
And Makanga, both Fabrizio and Makanga from NMCP Tanzania. So it would be nice to hear from their take on this.
Yes, please go ahead.
Okay, now thank you to allow me. It's just a small contribution on the IPTP coverage. But before going to the IPT coverage, a clear indication for the IPTP implementation has been done with very teeny evidence of a couple of studies in Malawi, and become a policy throughout the African region in a very short time. I mean, this is just to respond to Umberto. They say that we have to provide very robust indication for other preventive therapies to the Global Fund or the international developing communities in order to make the acceptable for them the initiative. But it's just a reminder. I mean, in the past, we did introduce a very not sophisticated, but a very durable initiative like IPTP with not that massive evidence. The evidence came out even after the introduction that in Tanzania was in 2001, and the introduction of IPTP has been done without a single trial in the country. But anyway, according to our health facility information system, the service is delivered up to, let us say, a proportion of 85–90% of the pregnant women attending the facilities are given SP, at least 2 doses, and around 75–80% 3+ administration of SP. So it means if the drug is available, the service is delivered. I think that the figures that we are constantly using at global level are figures coming from the malaria indicator surveys that, believe me, I think is a quite difficult indicators to be monitored, because is including, I think, 2-3 years recalling of the previous pregnancy and so on. I mean, a lot of biases, but the current global indicator used is the malaria indicators survey type. But in terms of health service delivery, I mean, if the women are attending the facilities regularly, I think the coverage, at least not the coverage, at least the proportion of them getting the service is quite high. And this is not only related to IPDP, but even to delivery of ITN through the reproductive and child health delivery. Yes, I'm over.
Yes, Dr. Makanga, please.
Oh, thank you very much.
Thank you so much, Fabrizio, by the way. And that's interesting that we didn't have much evidence except for these early studies from Malawi. So it's really interesting to hear that. Dr. Makanga wanted to contribute something on this as well.
Yes, so thank you very much for the organization. I would like just to contribute something on the drugs that we have been using in Tanzania. Here in Tanzania, by NIMRI, I'm from NIMRI, Tanzania. We conducted first the clinical trial for the IPTSC, which is for the school children, where we use 2 drugs, DP as well as artesunate in our ASAG. And both of them worked well. And of course, the protective efficacy was about 70% for both of the drugs. And in this trial, we did also monitoring of drug resistance markers and so forth, as well as other parts of acceptability and feasibility of implementation in a wider scale. So what we saw from the clinical trial is that those both 2 drugs were good alternatives for the IPTSC policy in Tanzania. And also we could see that actually IPTSC was serving the purpose that it is reducing development of resistance in these communities. So we have some data that will come up under publication later, but we just that in a nutshell that we saw the reduction in drug resistance markers following the use of these IPTSC regimens. And then on the implementation aspect, we went ahead with the DP, where we developed the implementation research aspect, where we were collaborating with the NMCP. And this we had to go to the 3 districts. And then from there, we also saw that DP, in terms of how it works very well. It was very highly acceptable, and it was also very effective. And we could also see that there was quick acceptability in terms of the collaboration between the guardians and parents and school teachers. It was very good and high. And so from those perspectives and the other studies that have been done for ACMC and IPTI in Tanzania, for now going to the policy aspect, we think, I would advise that the country should continue with the drugs that are already known, which have been already researched and have already gone to the implementation phase. So once we introduce this program into the countrywide programs, then we can later on discuss on whether we choose which molecule to change with. But however, for the starting phase, I think countries should go with these molecules that are already well known, and then later on you can be able to change, but you already have the program already in place that is ongoing, just like the NTD program where they can give albendazole now. Next year they can give another drug. So each is, they use the same platform available. So instead of struggling which drug to do and which one not to do, I would just advise the government to just use those which have already been researched and they have been used. For example, for instance, in Tanzania, they can just use either artesunate or DP, and then they can go forward in that aspect. And then I just want to add, there was a question from Eric. He was asking how can we justify IPTSC if there is a big high risk in children under 5. Of course, we see the mortality in children under 5, but if you compare the risk who are at risk in asymptomatic parasitemia, who are carrying parasitemia in the communities, you find the school-age children are twice as much higher at risk compared to pregnant women. And the two are very highly correlated. We have done a systematic review. One can go and see it. We saw the correlation is about 93%. So if you intervene in school-age children, you are likely to reduce the reservoir in the communities and as well as improve other programs that are already ongoing, like for IPTP or the others. And again, for the school children, they are mostly asymptomatic, but they are also having a high burden of anemia, which is related to the parasitemia that they are carrying. In so doing, they become, in terms of development, they have lower cognitive development, or they become impaired. And so they have poor performance at the schools and so forth. So if you look broadly, you find that IPTSC is an important intervention for these particular children. And we can have our discussion much broader, but I think there is a much more gain in reducing, in intervening in the school-age children. Thank you very much.
I see Geoffrey is really making the case for intervening in school children. Makanga, we're going to have a very long conversation about that specific IPTSC.
Yeah.
No, but thank you so much for the introduction. Looks like this is, of all of them, this is like your favorite. But I think you make a fantastic case for that. And thank you so much. Back to you, Nana.
Okay. All right. We've talked a lot about some of the challenges here in supplies across all the different strategies. I wanted to go back to, we have Corinne and also Dorothy here, just to ask Corinne, can I take a question here with you to check with what is RBM doing at global level with regards to logistics and supply?
So first of all, I would like to thank and congratulate WHO for this new guidance on chemo prevention. And the beauty of this new guidance, it's really encourage national malaria control program to expand access and then also to improve the strategies as well as the guidelines, and to be adapted and implemented using their local context, as we are seeing with the National Malaria Control Program of Tanzania. And I want to congratulate the program for the work that they are doing, as well as the fact that they are trying to get evidence for them to decide on where and how to implement the chemo prevention so that it can be effective. So in terms of what we do at RBM, Partnership to End Malaria. So basically what we usually do, we facilitate the deployment and scale up of new products, techniques, and implementation. This is one of the objectives within our vision for, of course, to end malaria. So we help countries to incorporate the mix of new tools and best practices, so that can be included in the strategy to ensure that they increase access to high-risk group. And here we are talking about school children under 5, infants, as well as pregnant women. So it's good that Jean-Louis was starting to talk about what we do at RBM. So at the global level, we have the partners committees, where we are coordinating all partners around all the support, both at national and regional level. And we have one work stream. For instance, I will talk about the SMC Alliance that Jean-Louis was talking about. So it's convening all the partners who are supporting countries, and they're discussing on all the elements that help countries to really implement SMC. And I'm sure we are going to see how we can even expand this to other chemo preventive measures. So at the global level, we also have at RBM a dashboard where we are supporting countries to track all the stock out in terms of the key commodities. And this helps us also to track the challenges of stockout, and then support countries try to address all the bottlenecks of the implementation of the intervention for the chemo prevention. So in terms of the enough supply, I think that we are better now compared to previously, because if you look at the World Malaria Report that was published a few weeks ago, you saw that now we are having 35 African countries that are implementing IPTP, as well as 15 countries that are already implementing SMC. So we are seeing that countries and MCPs are really are adopting those new guidelines and implementing. Of course, stockouts are there. There are many challenges, health system challenges. And then this, of course, on top, we also had the COVID disruption. But when you look at the data, we are seeing that there is increase in terms of expansion, the coverage of those interventions. Of course, IPTP is still very low, and we really need to combine our efforts to achieve our targets. So the good news also is there are also, in terms of supply, there are now increased producer of the products. So currently we are coming from one supplier to 3 suppliers. And as you see recently, MMV supported a country in Africa, in Kenya, that will also produce very soon and will be the 4th supply. So in terms of global supply, there is enough drugs, there is enough suppliers. But as Humberto was saying, it's really important that we invest a lot in the primary healthcare, and then the point of care and the point of delivery. And then, of course, this needs to be implemented under the country ownership, the country leadership. And of course, we really need to build capacity of this. And then we need a strong domestic support so that country can deliver and then reach the high-risk group, as well as our children, pregnant women that are living far from the health facilities. So briefly, this is what I wanted to comment on. Thank you.
Thank you very much, Corinne. Yes, like you mentioned in the slide, Fedros, I don't know if you can go back to the slide with the bar chart on the increasing coverage of SMC, I think it was, when we, we see, so we can see that this is on the crescendo, so it's going up. And we also have on the side the systematic review that was published by the Community Health Impact Coalition. If you don't know about them, I suggest you can read about them. This publication is really interesting and really good, and highlights the challenges specifically on stockouts, which you're talking about now, and the urgent need to address these that can be systematic issues in drug delivery. So
that was really nice that they have that we will have now more than one supplier. I mean, as more countries take up chemo prevention, you'll need a lot more of this. And I mean, maybe before we move on, it would be nice to hear from Corinne and also from Dorothy, if they have any specific advice to countries like Tanzania or Mozambique, or countries in the south of the Sahel who are gearing up for their next global fund applications for chemo prevention. Any specific advice from? And by the way, great job on the RBM. We are very proud of the work.
Thank you very much, Fedros. So actually, I'm here in Nairobi with the NMCP managers and delegates and the Global Fund. So we are hosting the Global Fund orientation meeting with all the NMCPs from Africa. So we started from Monday to yesterday. They were the Anglophone group, and now we started today with the Francophone and Portuguese and Spanish speaking countries. So first of all, this is what I say, the beauty of this new guidance of WHO, it gives flexibility to countries to adapt, adjust, and then choose what are the best intervention. And WHO with other partners have been supporting countries to do the stratification as well as the subnational tailoring, so that they can choose the best and most effective malaria control intervention based on the local context and using, of course, data. And we here at the Hold Back Malaria, of course, in collaboration with WHO, we are supporting countries, providing technical assistance to support them, first of all, to do the malaria performance review under the leadership of WHO, so that we can identify the area where they need to improve, and then to also develop their strategic plan, because for a country to submit to the global fund, you have to have a strategic plan that will guide the country on what are the objectives, the goal, as well as what are the key intervention, of course, using local data. And then also in terms of all the technical guidance, it's coming from WHO. So countries are choosing the best and most effective malaria control intervention, of course, based tailored to and targeting the area of malaria transmission for them to get impactful outcome and then reach the target. This is what we are doing. And then, of course, it's important to note that the Global Fund is not only the sole funding partner for our countries. We also have the Presidential Malaria Initiative, so who are also part of our key partners. So everyone is sitting on the table. The country show the strategic plan, and then the country choose where what are their priorities. And then it's also very important, it's also a call for us to also ensure that our countries invest also in their malaria response. It's really important that they increase also domestic funding. So maybe this is what I can say before my sister Dorothy adds on. Thank you.
Thank you. Thank you so much. Dorothy, do you want to add, or shall we move forward and come back to you later?
If that's what you want, I can keep my comments for later.
If you're available, I think we should.
Yeah, okay. Maybe probably very, very quickly. Corinne has mentioned a few things which I wouldn't come back to, but I wanted to actually highlight the need for evidence. And I want to congratulate Tanzania for already trying to accumulate what we need, because they want to see impact, they want to see feasibility, they want to see how it is fitting into the entire strategy of the country. And if it is already, as it is already in the NSP, it's a good sign. The second thing I wanted to say was just about prioritization, because as Professor Mboto said, there are lots of things the country may want to do, but you must prioritize because the resources are limited. So we must look at the most impactful. And of course, we begin with those that address the vulnerable groups and which are always on the table, like IPTP for pregnant women. And then we look for another intervention for children. And then, of course, you have to address your vector control and your case management first before you go into adding other things. And as you're adding, you are showing added value of impact, either through models or through studies that you've done on the ground. And the third thing I wanted to just add is about the drugs. So adding drugs to any system introduces risks and pressure on the procurement and supply chain. So I'm happy Tanzania says they have a very good supply chain, but some other countries have complicated supply chains. Quantification may be an issue because you don't have all the parameters, so you need to properly quantify, because I'm saying that this is a project mode, but if we are going with Global Fund, we are talking about a program implementation, because the project mode may not be as impactful. We have to see how to really bring all of that to scale. And then lastly, the type of drugs that we use, and the pressure of the drug that we're going to create through all of these additional chemoprevention strategies will need that we actually strengthen the surveillance of drug resistance. I think you will want to address that later, so I'll just leave that for now. Thank you.
Yeah, definitely. I mean, we have a number of questions on these issues, but Dorothy, the point you raised about gathering data is really important. I think as you were speaking, this is a message that we probably should share more. That is that countries have quite a lot to learn from places like Tanzania. I mean, the way the Tanzanian NMCP is coordinating this entire machinery, you see that it's a very difficult machinery to organize in fairly difficult circumstances, but then implementing it with the prioritization, as you say, allows you to actually move forward with the ones that give you maximum impact. So how do you bring in data to the subnational tailoring, to the prioritization? I think these are a lot that we can learn from our colleagues in Tanzania, and hopefully we're going to hear more from them in this masterclass. So colleagues, if this is okay, we're going to move forward a little bit, a few more technical questions for our experts here. There's one thing that came up in the beginning about some early concerns about immunity, and I think David raised this as one of the reasons that chemoprevention took so long to adopt in mass, if you like. And here there were some original questions. I think that there was an interesting paper by Clara, Professor Clara, in the beginning that was from Tanzania, actually. I think this work was done in Ifakara, I believe, that demonstrated that, chemoprevention in kids was a good thing, but it kind of led to this rebounds effect. You have some form of impairment. So kids who had chemoprevention ended up with more malaria at some point. We have a review by Ann Wilson here that suggested also a slight increase in infections among kids who had taken chemoprevention. And then here is a study by my colleague, Dr. Ali Olotu. This was from the vaccine side, on the early days of RTSS. And here they also saw that 7 years down the line, the kids who had gotten RTSS ended up with a lot more malaria than before. So we used to have these concerns before, and it would be nice to hear from our colleagues here, our experts here, whether these questions have been resolved now, how they have been resolved. I think I heard earlier someone was saying that the benefits outweigh the risks, but can you guys provide some clarification here on the question of immunity and chemoprevention, especially in kids? So nobody specific here, but any of our experts can jump in and address this question.
Well, maybe I can start, but there has been there's been a meeting in Geneva. Oh, David, you want to? You organized that meeting. Maybe
go ahead. Go ahead.
Right. Yeah. Oh, okay. So there was a meeting in Geneva to address really this question, and there was also a systematic review. I think it was done by Catherine Guinovar, and the conclusion were that yes, there is probably a rebound effect, but that rebound effect is not as big to really be problematic. But in any case, there was actually a sort of suggestion to actually include for any study on prevention, to include also a time to look for a rebound effect, because actually the amount of data available is quite small. So yeah, this is rebound effect. And for example, a study that was done here in the Gambia by Brian Greenwood on chemoprophylaxis in children, they show actually a rebound effect after the children got out of the age group that was targeted for chemoprophylaxis, but that rebound effect did not translate in higher mortality, for example. So yeah, I don't know, David, do you want to add anything else?
Maybe I just put a link to the report from the meeting that Umberto mentioned in the chat. And it was a good discussion, reviewing all the information on concerns about rebound in the context of chemoprophylaxis and chemoprevention studies with the vaccine, with vector control as well. And the conclusion was, I thought, very reassuring. I mean, it recognizes that it is a real phenomenon. If you prevent exposure to malaria, you will impair the development or maintenance of naturally acquired immunity. And therefore, when you stop the intervention, you will be at increased risk of malaria for a period of time. But so far, all the evaluations have shown that the benefits of the intervention far outweigh the risks of the rebound which may follow. So that's reassuring. But a caveat to the conclusion was of the meeting was that as we move forward, we're striving to do more and more to prevent exposure to malaria and to prevent the disease and death that we're all too familiar with. And the hope and ambition is that we will have more interventions which, even if individually they're not 100% protective, when we layer nets on chemoprevention, perhaps with the vaccine, perhaps with monoclonal antibodies in a few years, we may well get to a point at which the prevention of exposure is so good that there is an overall increase in risk subsequently. So although the meeting concluded that with the tools that we've got at the moment and the ways that those tools are used at the moment, we do not need to be concerned about the rebound phenomenon. The meeting also said we should also just bear in mind that as we get better at preventing malaria, we should not entirely forget the possibility that rebound could become a more significant public health problem. So I hope that helps to clarify. And if you're interested, I do recommend the link to the report of the meeting, which I think contains a link to the review that was discussed at that meeting. Over.
Excellent, David. Thank you very much. Just wanted to ask the Tanzanian NMCP to let us know if they factor that in the long term of their study to measure rebound. Dr. Lusasi, I don't know if you're there.
If I can help Dr. Lusasi.
Yes, you can.
Thank you so much.
Yes.
I think Dr. Makenga can talk on.
All right. So if I can, in Tanzania, we did an IPTSC study in a clinical trial setup where we had 1 year of intervention, and then the other year, the second year was no intervention, in which we wanted to evaluate if there is any rebound effect. And we also actually followed these children for other questions like immunity, in terms of natural immunity and so forth. But however, we saw that in the first year of intervention, the intervention worked very well. And then the benefits that we saw in the first year were almost all gone in the second year where we didn't give any intervention. So we suppose that probably this kind of intervention, once you start, for example, IPTSC, then it should be continuous until when you have a substantial reduction into the parasitemia in those particular communities. And I think that can also be go in hand with the modeling aspects, where we can model how long you can do IPTC, for example. And then later on, you can see when can you exactly remove IPTC and continue with other elimination strategies, for example. So I think rebound concern should be considered in terms of whenever you stop those particular interventions. But also the mark that we saw in this particular non-intervention here was not that much higher compared to the baseline. So it was just similar to what we saw in the baseline, which was not that much, I can say, a cause of a rebound, first the removal of the intervention. Thank you.
Thank you very much, Geoffrey Makanga. All right, so perhaps move to school.
Yes, before we go to school, I saw the hands of Professor Jean-Louis.
Okay.
Yes, I mean, I was just
Yeah.
I was just, I don't know, Fedros, if you know Jean-Francois Trapp and Christophe Roger. Do you know those French malariologists?
No.
That was very.
I should know. I'm sorry, I don't.
Yes, very nice researchers who published in '96 some very provocative papers about the same question, but about the mosquito nets, saying that I mean, if you protect people a long-term protection in the high transmission area, you will definitely have rebound of morbidity and mortality because they will lose immunity as well. So at the time there was a lot of question, a lot of discussion, but we ended up, as you said, maybe for the 1 decade after that, we saw that the very efficiency of the mosquito nets, and the same happens. So I think to SMC, even though we have a little rebound effect, I mean, protecting children where they are at high risk of death in the under 5 will still be beneficial. And when they will go out to the SMC or the prevention period, I think they will get more strong, maybe more skill to be fight with the other diseases. Over.
Well, thank you so much for that, Gilles. Appreciate it indeed. You know, this is kind of counterintuitive, really. Like, you know what, that which protects you also exposes you. But as you guys have explained, there is really all the reasons for us to keep going forward with that. So as Nana suggested, let's discuss a little bit about the intermittent preventive treatment in children. But first of all, we present here a brief review done by our colleagues here. Really, you know, asking the question of whether the current malaria strategies are ignoring school kids. And you know, this is an important question when you think about things such as the way we distribute bed nets. Here is a study by colleagues including Brian Greenwood and David Schellenberg on the call here. You see here some very nice suggestions, but in that paper, you see this crazy evidence here where the use of bed nets in the school-going age kind of just dips. You know, and this is evidence that you also see in large-scale studies. This is a study by Hannah Cohenkor's team from CCP in many, many different countries. You see that little dip there in the early ages, in the school-going age, kind of that is the time when bed net use is lowest. So you start to say, hey, are we ignoring school kids in our malaria control strategies? We see this data from Uganda. I think someone mentioned it earlier, where school kids are actually contributing most of the ongoing malaria transmission. Work by our colleagues, including Dr. Rek, a friend of ours from Uganda. There's very good evidence here that school kids are contributing most of the infections. You see that here. So put that together. You know, the fact that school age kids have most of the infections, and they are the least covered by our other prevention techniques. I think then the question that was asked by Professor Jimde and colleagues was very, very relevant. Are we ignoring school kids? And therefore, it makes a lot of sense that we start to implement IPTPC. And I've seen the author of this paper is on the call, so this is really, really nice to have here. And we would like to listen to our experts and talk to us a little bit about this. And I'm going to ask my colleague Nana to start that conversation going forward.
Thank you very much, Fergus. Yes, so certainly there will be challenges. And one question I wanted to ask is, how would we expect the delivery mechanism to be? Is that going to go through schools, or is that going to go through the homes? What can you tell us?
I'd be happy to get the ball rolling if that helps.
Yes, please, David.
Okay, so and also just picking up on some of the points that are being made in the chat, some fairly vigorous exchanges, and it kind of, you know, the question being, school children are largely, well, they're frequently considered asymptomatic, even when they're you know, when they're infected, and at low risk of severe disease and death. So why would we want to prioritize them over chemo prevention or other strategies targeting young children, children under 5, women in pregnancy who are at greater absolute risk of severe disease and death? And I'm just looking at the WHO recommendation for IPT in school children, and the second bullet point under the recommendation does say malaria programs can consider IPTSC if resources allow for its introduction among school-aged children without compromising chemo prevention interventions for those carrying the highest burden of severe disease, such as children under 5 years old. So it does make that point. We also see in the chat the recognition that this may not only be a health intervention, but an educational intervention. We also have this question about the extent to which chemo prevention in school-aged children might help to contribute to reduced transmission, benefiting not only the school children, but the rest of the communities. This was certainly discussed during the guideline development process, and it was recognised that although it makes sense in principle and in theory, and modelling supports this, actually to date there's no substantial evidence that intervening in school-aged children reduces transmission. And because of that, I think this all fell into this recommendation that actually we prioritise those children who are experiencing the highest risk of severe disease and death. We prioritise them, but if at all possible, you know, there are clear benefits to also catering to the needs of school children. Another reason perhaps this was not sort of pushed even harder by WHO at this point, it probably relates to the lack of large-scale, longer-term operational experience with the use of chemo prevention in school-aged children. And do note how the recommendation is formulated. It talks about school-aged children, not school children, recognizing that, for instance, especially in West Africa, parts of West Africa, school terms and the periods of malaria risk don't nicely coincide with each other. And therefore, it may be necessary to have means to access school-aged children which go beyond the schools themselves. I think it's also important to recognise that access to education and access to being at school is also unfortunately not universal, and it would be really sad to see somehow existing inequities reinforced by a malaria control strategy. So I think it's also very important when thinking how to deliver chemo prevention to school-aged children, we bear these points in mind. I'll leave it there if that's right.
Thank you, David. It's a very good point about the universal access for everyone. Yep, to have that in consideration. There are some very interesting
I think Jean-Louis has his hands up
in the chat. Fergus, do you want us to bring some of them up, or I can see?
Yeah, we should, but I can see Professor Jean-Louis' hands up.
No, it's Jean-Pierre. It's Jean-Pierre.
Oh, Jean-Pierre.
Jean-Pierre, yeah.
Okay. Yes, and then we also have a signal from Tanzania. We would like to hear their implementation of IPTSC in Tanzania, and what their plans are with regard to the Global Fund application and whether that's going to be included as well. So let's start with Jean-Pierre and then.
Good afternoon, everybody. Do you hear me?
Yes, we hear you very well. Bonjour.
Okay. Yes, bonjour. No, I like very much the discussion, and it's sometimes it's like discussion goes like we have to make a choice, but I don't think it's about choices. Everybody knows that under fives are very vulnerable, and under ones are the most vulnerable and should be the most targeted. But if you have an intervention in a group that's very easy to reach, you don't have to go to the villages, you don't have to wait till they are pregnant and come to your place. They come to the schools, and I think the school attendance rates are quite high in a lot of countries today in 2022. And if they are easy to reach, and if for every euro or dollar you spend, you get in your national malaria control program more dollars back because you save money on the curative side. So that means you have more money at the end to target your under fives and everything. Then I think it's very obvious what you should do. Secondly, this is a very easy intervention. You don't have to spend money on the field. Secondly, if you have more money at the end, means also it's the same logic for drug resistance, because you save money in the curative side means you save money on drugs, meaning that in fact an intervention where you spam drugs, which gives you the impression that you increase drug pressure, in fact decreases drug pressure because you save money and save drugs on the curative side. So at the end of the day, you have an intervention which looks you have another priority, but it's a fake observation. In fact, you have more money for your priorities, which are children under 5 and the most vulnerable if you do this. And it has a lot of collateral advantages, and we're talking about knowledge and we talk about health, but there are a lot of other interventions. To my knowledge today, the main interventions are always against helminths, schistosomiasis, helminths, but there is nutrition, there is prevention of chronic diseases, there is a boost of immunization that have to be done in school children, and malaria IPTSC could serve as a platform for school health, to have more attention for school children for a lot of diseases and not only malaria. So there is a lot of collateral things around this that may happen. So this, for me, after all those years, there have been a lot of evidence now in Kenya, Malawi, Congo, Tanzania, and now the implementation is there also. I think the case can be made.
Even though it's it's conditional evidence with low certainty evidence.
Yes, that's true in the guideline of June, but at least it's there now.
Back to you, Nana.
Okay, well, perhaps you can go to Dorothy. You can tell us a little bit about multisectorial approaches and how to improve prevention in school-age children, now that you're at WHO Afro.
Well, I'll still have the program perspective.
Certainly.
Thank you very much. Actually, the question about school-age children is very relevant because some studies have been done and they have really shown the higher prevalence of malaria prevalence in these school children. And I think the argument, which if we want to take it up, because so many countries have not yet implemented at scale, apart from the projects that are going on. But if we want to take that up, the angle which can be most convincing may be the anemia and the morbidity that may cause in the long term in children and their capacity to learn. And that's why I agree with David when he mentioned that it's more like an educational intervention, because when it comes to prevalence and the other effect on the other age groups, there is no evidence. It's still in theory, and we think it may be happening in high burden settings. The effect may be very little because there are other age groups that carry the transmission compared to low transmission areas. So we must contextualize when we do that. And so maybe the question would be, what is the added advantage using this strategy in a high burden setting compared to a low burden setting? So in terms of reduction in transmission, in terms of that, maybe that can be a research question. But in terms of educational, yes, it has an impact. And if we have what the resources are, of course, SP will normally not be the drug of choice, and we can think of other ACTs, and in that case, using other ACTs, we can expect real results in this age group. Thank you.
Thank you, Dorothy. Jean-Pierre's got his hand up.
I think that's the legacy hand. I think first of all, thank you so much.
That is an expired hand.
Yes. First of all, thanks a lot, Dorothy, for this, and the emphasis on how we can bring in the different aspects into the school system, and also the point about anemia. This is fairly interesting, given that kind of ignored sometime when you talk about this malaria prevalence and all that. So it's really nice to hear the point about anemia. Maybe it's something that we want to come back to and express a little from a case management perspective in this age group. But first, it would be nice to hear from our Tanzania colleagues what their results are. First, again, you could just go over once again what the findings were for IPTSC and what your plans are with regard to this going forward, especially with regard to your forthcoming round of the global fund application. So our Tanzania colleagues, any one of you can jump in, or maybe Dr. McKenna.
Okay, thank you so much. For a very good question.
There's echo from your end.
This is a platform very valuable for us as a country, and we have been waiting for a long time to see the science, what the science says regarding IPT school and others. But at higher level, in the Ministry of Health, we are still waiting this discussion. And again, we're going to the table and to see the way the program, how could we conduct this intervention. Although the IPT school is still competing with the other intervention, which is in the place, and some of it, the coverage is still low. So we are thinking during the coming cycle, global fund cycle, funding cycle, to request the fund at least to start if the higher level will permit to start these interventions. Okay, thank you so much.
Maybe I can add.
Geoffrey, did you want to say something, Geoffrey?
With regard to IPTSC in Tanzania, we conducted a very good journey from the clinical trial then to the implementation. Sorry, Lusasi.
Hello.
Yeah, it's fine. We Geoffrey can go ahead. No problem. I can hear you.
Right. So I was saying from the Tanzanian side, we have gone from the clinical trial then to the wider implementation research, where we involved the 3 districts that we already Rusasi explained to you on the slides that he had, where we covered almost over 127 schools with over 73,000 children. And it was very effective and feasible. And then from there, once we got those results, which were very good and promising, then we developed the malaria and preventive policy, especially for the IPTSC, for example. Of course, it's also the policy also incorporates other preventive therapies like SMC and so forth. So we have gone to that level where we already have the policy, which is still waiting for ministerial decisions, where, as Rusasi has already explained, Then once we got the go ahead, then we can do that. So the strategy is we go through a quota of the districts that we have already, which are high endemic in Tanzania. And then once we have gone to those quota of those districts, then we will go broadly down to the other districts, which are moderate and high endemic, according to the stratification that was done in Tanzania. So once we get that, then we can be able to spread, and we can be able to shrink the reservoir in these high endemic areas where you saw the map, which are already covered. So those are the strategies that we have currently with the NFSP. Thanks.
Thank you. Thank you guys so much. Dear friends, we are asking you to stay on the mute side. I just want to, again, emphasize our intention to provide as much reflection as possible on the Tanzanian results, but also, reflect on how this may be applicable in other countries in the south of the Sahel. So if there are like NFCP directors from other countries here, or members or people from the other countries in the region who would like to jump in and make comments on this, please feel free to do so either in the chat or just by raising your hand. So Nana, I think this is back to you now.
Yeah, okay. So there's one important thing about taking all these drugs that we'll have to also mention, which is access to clean water. What are your perspectives on access to clean water for taking all these drugs? Perhaps you can start with the program, Dorothy.
Right. Probably I would have been happy to hear about Tanzania's experience, because this is really a big challenge for us in Cameroon. Access to potable water. Anyway, potable water is drinking water. Whatever water that the family drinks should be able to be used to administer the drugs. But the challenge is there is an aspect of communication which is neglected. Where it's worked, like in Ghana and in other places where there is really a direct observed therapy, is that the women come to the facilities with their own water, because most of our health facilities do not have enough sufficient water for all their clients. They could have for the patient or for the staff, but for all their clients may be a challenge. And even the containers to get the water from the cups. And we amused ourselves by putting all of this in the intervention planning and procurement, but the management of these commodities is always a problem. So it's always easier when women come with their bottles of water and they can drink on the spot, because the risk is that when they don't have that water with them, you are tempted to give them their drugs to go home, and you can't confirm whether those drugs were taken or not. And and that's what is happening. Most of the cases that are reported as IPT coverage administration are usually not taken, or are not observed. So we have an implementation gap there. Yeah. And we'll be happy to hear how other countries go about it. But I've given the example of Ghana, and the women are called, reminded, and the communication is ongoing, engaging. And so they know that when they're coming for their ANCs, they bring their bottles of water.
Thank you very much, Dorothy. And yes, I do know the experience from Ghana as well. And yes, please, our Tanzanian colleagues, can you please share your experience in the studies, how, and also in the generals program, how is this managed?
Yes, I can share experience from Masterclass and the new district. I think the best practice is to use clean water which is available in their community. So don't bring your bottled water to the community. But use the available water which is clean, available at the community level. Then it becomes very easy. not introduce bottled water, which is not available. Then it will be difficult for them to take medicine. But use clean. Sometimes the clean with inverted comma, because a lot of water which is available to the community level may be not very safe, but clean. You cannot say sterile water, but it's clean enough, and they are using their daily activity.
Yes, I can also add on what Professor Gisala said.
Yeah.
Can I do so? In the IPTSC study, we also encourage that they should use the common water that they usually normally use. In most of the schools in Tanzania, there have been wash campaigns where they build some wells and other methods for where children can get their drinking water in a usual way. So what we did is just to give them the drugs to the teachers so that they can be able to deliver the drug, to administer the drug to these children using their own water that is already available at school. This also comes up with the aspect of food. For example, delivery of these programs like IPTSC, you normally have to have food in the afternoon for lunch for most of the children. Yeah. So usually we also encourage the parents and guardians to bring, I mean, mostly through the school committees, they usually prepare food which will be available. And for example, in Tanzania, this particular intervention which we had conducted in high endemic area, the parents were so cooperative. They could bring food and they could also cooperate in terms of cooking and also distributing that food to their children. And even some could even come leaving their jobs at farms or whatever, just to make sure that their children get the medication before they go home. So those are the things that you can endorse and encourage those communities. And especially in collaboration with the leadership within the village, the district level, the political leaders, and all key opinion leaders should be encouraged, and then they can be able to do such a campaign and encouraging or teaching people on the importance of such intervention. And then they come up, and that also reduces a lot of implementation costs. So you don't have to buy water, you don't have to buy food, but they can do it. They feel that is their own responsibility. Thank you.
Thank you very much. Can I just ask one more question with regards to this about the water and other general aspects? During these administration of drugs in campaigns at school, do you take advantage to like general education as well, not only on the clean water and also like washing of hands and general malaria education that would feed back to the house and also then generally rebound to the community as a whole? Was that involved? Was that part of the study when you did that?
So as part of the study, you have to consider we have to train a lot of training from the village, the communities, the teachers, and so forth. So there's a lot of layers to go through, and towards the community itself through the school parents meeting, where we gather and we tell them what we are going to do, because they're also concerned that you give the drug through a teacher who is not a nurse. So you have to address all these issues, because even for him or her as a parent, once he goes to a hospital, he can be given the drug and give it home give it to their children at home. So it's just the same thing. So we have to educate them on all these aspects and how we can monitor the adverse events, for example, and how they can report them to school. And we usually had to collaborate with the regulatory authorities in Tanzania, where they have their own IDR reporting system, which were very useful for them as well, to make sure that all communities are aware of it. And it was very good that they could also report, and we could also do monitoring in a real-time manner. We developed our teams with the regulators and NMCP people and other from the district perspective. So this made us make a very successful way in convincing to the parents. So we can see also the coverage was also increasing from the first round, the second round, and the third round. We were going to 80%, which was very high, which is consistent with the school attendance. And also this comes up with a question, I think one of the experts explained about equity, where can we reach these children? Yes, they are almost 100%, school age children are almost 100% enrolled, but usually school attendance is not that much 100%. So there are children who are outside the school, and there are those who they're not even enrolled, but they're school age. So what we did for us, we used the community health workers who were working in hand with the school age, with the school teachers. So whenever they find that the child missed school, then the community health worker will go fetch that child at home, and then they give the drug there. So the same mechanism can be used to for those children who are in streets, in orphanage centers, and other places that cannot be reached, but they can be reached through this particular organization within the local perspective of the governments. Thank you.
Thank you very much, Geoffrey. And there's a hand, John Pierre.
Before John Pierre, Nana, I just want to, forgive me, John Pierre, we're going to bring you in. And also I saw the hand of Dr. Muhyiddin Mahende. I believe he's also from the Tanzania team, so would like to hear those opinions. But you see, Nana, I'm a little sad actually when you see these studies that, we have the medicine, but now we don't have the water.
Yeah.
It's one of those things that if we just approach malaria as a public health problem, you lose it, because then here you have to bring in the Ministry of Water, for example, to have a pipe in every school or every health facility or whatever, so that there is always clean water. It's a multi-sectoral program. Education, like our colleagues from Tanzania are saying, what do you tell the mothers about the food? Some of these medicines you can't take empty stomach. And so, we were doubting when we were preparing the masterclass whether this question is even worth asking. But as you can see, dear colleagues, that overall in malaria endemic countries, we have to do a lot more beyond just addressing malaria as a public health problem. I think that there's just a lot that we have to do right, and some of them are very simple things. I also wanted to point out that the authors of this paper are with us here, Andre, my friend Andre, and Celine. I believe you guys are still on the line. And if you don't mind, if that is possible, if you could just come on real quick, one of you, to clarify, what were the main challenges here? We noticed that you addressed the question of water access as a major concern. It would be nice to hear from you guys before we go back to our global experts, to hear from them as well on these core questions. Yeah, Nana, if that's okay with you, we can invite either Celine or Andre. Yeah. Bonjour, Andre. Are you there?
This is Celine.
Oh, Celine. Celine, go ahead, please.
Celine, yeah.
Yeah, thank you. So feel a bit put on the spot right now, but what you highlight here was a survey we've done 3 years ago, where we're trying to understand what were some challenges in the implementation of hesitancy and IPTI. And that's something that really came back. So we'll have to look at, it was a selection of countries. It wasn't necessarily general. So that's just a flag here. But really, that was a theme that came back very often. And we were talking to nurses, health facility professionals, and they were saying that this access to water was an important limitation in the upscaling or the coverage of this intervention. So I don't know if that answers your question. Or if you want a bit more details, but yeah.
No, that's good. I think for us also just to say thank you guys for highlighting issues like this that might look like non-important, but really, really important. Yeah. So I see that Muhyiddin is rejoined. Go ahead, Celine.
Yeah, it was really the purpose of this project. This is a market research, so it's a bit different from clinical trial and what you would usually see. So it's not necessarily representative. It is indicative, but we feel is the importance of this type of research is to really hear the voice from the field and things that you may not hear as loud and clear when you do clinical trials that may be a little bit more formatted and prepared. So that was really outside of any clinical trials. What are the experience? What were some of the barriers that were faced in the implementation of these interventions? So that's, again, small sample, very indicative, but it was strong enough for us to have that as one of the main conclusion and takeaway from this research.
Thank you. Thank you so much. Back to you, Nana.
Yeah, I think Jean-Pierre wanted to say something. Jean, your hand's gone now.
Yes, it's in fact you hear me?
Yep.
Yeah, it's in fact an anecdote, because when you talk about end user, when the dissemination took place, because you have clinical trials, but then you have implementation research, and the implementation research they talked about was targeting 70,000 children, 70. So that's not a clinical trial, that's a real implementation. And at the moment of the dissemination, it's the first time I'm already involved in the past in several trials, which was of course smaller, but it's the first time, if you talk then about end user, that I had in the audience that the teachers and the parents or the people who represented the parents and the teachers during the dissemination start taking the word and were angry that they were in the control group, meaning that they say it's not equity, it's completely unethical to put us in the control group. Why were we not selected to be in the implementation group? And then I realized you can have a lot of evidence and talk as scientists about impact on anemia, cost saving, and no impact. But if the people on the ground, the end users, are angry that they are not part of the intervention at community, people from the community, from the schools, then you know, bingo, there is something here with this intervention that works, because people see it even after 1 year. You have the population, they start making food, they start getting the children who are not at school to the school to get it, they start making food at school to give it with the drugs. So you create a dynamic at population level, which is very positive. So it's anecdotal, but it's on top of the evidence that you see. If the end users all want this, then you know this is work. This is a good intervention.
Yep. Yep. Thank you, Jean. So, Fede, should we move forward to?
Yeah, maybe we should move forward. And now I want us to bring back our global experts on various issues around SMC and also IPTI. David, we're very lucky that we have you here, given that I don't know if you were a PhD student at the time or were a senior scientist already at the time, but your study always rings a bell when people talk about treatment for and we at Ifakara are super proud of this as well. A lot of these studies were done in Ifakara, so we are very happy with that. But we would like to go back to these early studies from 2001, I believe that's when this was published. Dave, are you still with us?
I am indeed.
All right. So broadly speaking, this has now become perennial preventive. What is the name? PPMC?
PMC.
Yeah, PMC. But I would like to have to hear from you and actually Umberto, about this time, and actually maybe first of all to Umberto, because when you published this, Professor Umberto published this commentary in the Lancet as a follow-up to your question, and he made two interesting points. He said at the time, Professor Umberto, if you are here, I hope you remember this publication. You said at the time that you had never seen a simpler intervention. but you were also concerned that people were not taking it seriously because it was not a vaccine. And you argued that if it had been a vaccine, it would be on CNN every day. So between the two of you, could you just talked to us about the excitement of the time, how important this was, and how this process has evolved to date. IPTPI, today
PMC.
PTMC. Go ahead, please.
Yeah, so it is to me. Well, I mean, I didn't remember that comment, but you know, at that time I was a bit more radical than now, and of course, this goes with age. But you know, yeah, you're right. Look, this is a simple intervention. You know, give SP when children comes to the vaccine clinic, and you have a decrease. I remember now between 50–60%, which is really fantastic. First only episode with more than 5,000 parts per microliter, 67.8%. Severe anemia, 50%. So it's very similar to what RTSS, or actually even superior to what RTSS, for example, which has been recommended for implementation does. So yeah, so I mean, I don't know what else I could say. I mean, it's a very simple intervention now that has been transformed to perennial malaria chemoprevention because it goes beyond it goes to up to 2 years of age. I mean, the only issue probably there is the use of SP. Which is the same thing for IPTP, so it's a monotherapy in a way. You know, SMC use SP amlodipine, for example. But beside that, you know, and also the other thing is that this intervention took an opportunistic approach, because it's like the schools took an opportunistic approach to say, well, here, you know, we have children coming to the vaccination clinic, we exploit this opportunity, take this opportunity to give treatment. So yeah, I'm not sure. I mean, this is my comment. Please, over.
Go ahead, David.
David.
Yes, I mean, Umberto, I've seen a comment from a colleague in the chat that we are probably encouraging too much use of medicines. So I'm not sure if this is related to the extension of IPTI to cover all ages, but maybe something that we can come back to. I've seen a comment from Dr. Nico Govella, my colleague here, suggesting that maybe we should be wary of too much use of medication. But anyway, let's hear from David as well.
Yeah, well, it's a long time since I looked at those Kaplan-Meier curves, and yeah, maybe just to pick up where Umberto kind of left off, being opportunistic. This was all about trying to retain some of the benefits that have been so clearly demonstrated in for chemoprophylaxis. Retain some of those benefits, but make it more acceptable, make it more kind of feasible. So building on the EPI program's schedule of routine contacts at the time, that was what led to deliver it 2, 3, and 9 months of age, alongside what was then DPT doses 2 and 3 and measles vaccination. And I think one of the key things that we have only relatively recently appreciated is that each dose will protect for a period of time, about a month. It's not rocket science. So if you give 3 doses during the first year of life, you protect for 3 of the first, 12 or 10 months of life, you get about a 30% reduction in malaria. If you were to increase that to 6 doses, you might expect closer to 60% reduction. The new formulation of the guidelines is interesting because it was deliberately, it left these issues, how many doses, what dose interval, what ages, it left those completely open so that countries could look at the pattern, the age pattern of disease, and say, okay, we see most severe malaria in 1 and 2 year olds. We want to target 1 and 2 year olds with chemoprevention. So it's this whole kind of we heard a lot a few years ago, especially about move away from a one size fits all to a problem towards an enhanced problem solving approach. People have been trying to solve problems for years. But here we have this this kind of permission, if you like, to look at the data and have your local strategies informed by the local context. And that's effectively what we did in that first trial in Ifakara. We saw the very high burden of severe disease and death in children under 1 year of age, and so we focused on contacts which existed in the first year of life. But since then, I think there are two sort of big shifts in the many malaria endemic countries, especially in sub-Saharan Africa. One has been improvements, thank goodness, in the malaria situation, and that leads to a change in the ages that are primarily affected by the most severe forms of malaria. We often see them in slightly older children now, in children maybe in the latter part of infancy, in their second and third years of life, and beyond in some places. So there's been a change in the age pattern. That's why it's so important not to have a one-size-fits-all recommendation from WHO, but look at the data. What's the age group that's most frequently being admitted with malaria? Let's target that age group. And then, rather conveniently, there have been a marked increase in the number of contacts between children and routine services, especially EPI program in the first year of life. But now there's a big push to increase contacts during the second year of life. So I think that enables us to make use of existing contacts to target children when they are most in need. This is another figure that I've not dwelt on recently, but this was the result. Following that first study in Ifakara, there were a number of other evaluations of IPTI, as it was then, and overall in all of these different settings, this was the results of pooled analysis across these different settings, a 30% reduction in malaria incidence. So that's what I said. You give basically 3 doses of treatment, they protect for about, because children were starting at 2 months of age. So that's 3 doses over 10 months in the first year of life, 30% reduction. It's not rocket science. The more doses you give, the greater the amount of disease you can expect to be prevented. My problem here, as you know very well, Fredros, is that I could continue talking for ages. So I deliberately pause so you can step in and.
No. I mean, I think that the expansion, the extension makes sense, and it would be nice, of course, if we can get more clarification on what the implications of this extension means to costing. So in the original format, it was definitely much cheaper than in the current format. If you're having to give medication much more than in the original IPTI format. So if there are any comments about how that influences the costing and cost effectiveness of the strategy overall, or costing, and that would be something that perhaps if we could hear from our colleagues from Tanzania, that would be great as well. But I do see Jean-Louis has his hands up as well.
Yeah. I mean, there was not about costing, but just a comment of about the IPTI. I mean, we did a study around 2006 from 2000 to 2009, and it was a kind of feasibility study before we ended up in Senegal to adopt and implement the SMC. But what we found is, given the burden of malaria, given the perception of the community, so during our communication, when we explain the advantage of that, I mean, mothers really keen to see that there's an additional benefit of the API, and that improved the API coverage, seeing that bringing their children to be able to receive antigens for some diseases and adding malaria on that, so that really improved the API coverage. That was a kind of non-expected benefit we got with the IPTI trial we did in Senegal.
So you're saying that the IPTI, if integrated in EPI, improves the performance of EPI?
Yeah, that's what we found here, because but maybe we were saying probably that could decrease the coverage of API. People may be reluctant to have these very young infants receiving pills during the API clinics. But mothers was really engaged and really perceived good benefit of preventing malaria, given the history of malaria and the burden of malaria they were facing in that young age.
Right.
Over.
Thank you.
Humberto?
Yeah, I just wish to make a comment because IPTI, as it was known at that time, was, I think WHO recommended it as an intervention before SMC. But the pickup of this intervention by countries was very low. And I think for the SMC, there was, I don't know, I think there was more organized. The consortium probably for MSC was more organized and pushed it more strongly than IPTI. So I don't know in terms of countries picking it up. And I know that there are some NMCP in the audience. I mean, how they feel about it, and so if there is real interest of picking it up. Thank you.
Dorothy, please go ahead.
Dorothy, please.
Yes, thank you. So there was some reluctance with taking up IPTI. And one of the reasons was, first of all, the fact that you have to cover just the first year of life. And we were like, what happens to the second and third year of life in a perennial setting? And with this understanding that when you protect a child when they are vulnerable, when you release that protection in the second year, you can have that rebound effect. Of course, now it's studies have clarified that situation, and the fact that these children remain vulnerable up to 3 years. Our question now is with PMC going up to 24 years, as David said, is going to increase the coverage of the.
We seem to have lost Dorothy.
Period of life. Hello.
We can hear you, Dorothy. We broke for a bit.
Hello.
But yes,
hello.
please
We can
go
hear you now. Go ahead.
Okay. All right. Thank you. So with SMC it was quite different because first of all it's a time-limited intervention, and we were seeing real large effects of during the transmission season, like the mortality and the overflowing of severe malaria cases in hospitals. And it was very clear that there was a need for an intervention in addition to vector control. So, and the effect was immediate, because when we began implementing SMC, we could see the rapid drop by almost 60% of cases, and even deaths reduced in these children. Whereas it's not been very dramatic reductions with IPTI. And I think we get this over a longer period of time, collecting evidence and showing that over time, we can also affect the reduction in severe cases. It can have, we can reduce the number of, the burden of the disease we have to deal with when we do IPTI for longer term. So sometimes the lack of evidence is also that what makes people kind of resistance. Now there is an issue of cost and coverage. There is an issue of cost and coverage, because when we say IPTI, we are in certain countries talking about the larger part of the country, which has perennial transmission, and the cohort of children we have to deal with may be high. So we need to integrate that in the communication, in the resource mobilization, to be able to reach coverage, sufficient coverage, and to sustain that over time. Now, with us going beyond 1 year, what has changed? Maybe that's going to be the question. What has changed, and how a country is going to be more seduced to pick up perennial malaria chemo prevention? And this will, I know the change in the game is the increase in incidence, the increase in mortality, despite vector control. So we are asking ourselves, what have we been missing that since 2015, for example, cases keep going up? Or what can we add and what can we do differently? And that makes the case now to say we can't do business as usual. We can't just do vector control. Okay, SMC has gone to a certain limit where the added value has started plateauing. So what added intervention should we bring on board so that we actually change the course of the illness? And that's why we have to think on this and see if resources are increased for malaria, it's going to really help to address these gaps. Thank you.
Thank you very much, Dorothy. What we seem to be running out of time.
Some fantastic policy questions there from Dorothy. I think because of the time, what we're going to try and do now is we will assign each of our experts a specific question, and then we will ask them to respond one at a time, and then we can do the roundup. So is that okay, Nana?
Yeah, it is okay. I've got one. I've got one to go. Do you want to start, or shall I go?
You can go ahead.
Yeah. Okay. So there's one that's quite dear to me. I think Fedoshi can go to quality. Yep. Okay. So you can see this image here, which is quite typical for those of us who are from or live in Africa, particularly in Nigeria, let's say, where we know that there's a very, as you can see, the quality of anti-malaria drugs is provided by public and private healthcare providers, and this is from Southeast Nigeria, and this is quite typical. So how do we guarantee that the quality of the drugs that are getting to the people that most need them are what they really should be, not drugs that have been sitting under the sun forever or not quality assured? So I think maybe David, I don't know, or Jean-Louis, I don't know who can take that.
I can certainly talk just briefly to say that I think this remains an underappreciated issue, that lots of attention has been given to counterfeit drugs. So those are drugs which have been deliberately made to kind of look like an authentic drug, but maybe they don't contain any active ingredients at all. But actually, the work that Harper Cash-Kaur and her colleagues, along with colleagues in CDC, have done, has drawn attention to actually substandard drugs, so drugs which may have degraded once they've left the factory gates. And there are various studies. I must confess to not being completely up to speed with all of this, but the various studies that have shown that actually these substandard drugs are pretty widespread. So I agree with you that this is a concern. I think it's a particular concern when it comes to treatment, because when you're treating somebody, you've got somebody with a potentially life-threatening episode of malaria, and you need to be absolutely confident that you're giving them a good quality anti-malarial drug. There are various efforts to try to improve the quality of the drugs that end up in pharmacies or in the private retail sector. And I guess, you know, that could be a good subject for another masterclass.
Yeah.
We won't be able to do it justice in 5 seconds. So maybe I should just leave it there.
We are definitely going to have a second masterclass on chemo prevention, and hopefully that next time we will have the Tanzanian NMCP joined by another NMCP, or maybe 3 other NMCPs. But Nana raised an important question. I see this sometime also, that people are carrying all this medicine, and you're like, is this regulated? the sun a problem when this medicine is in the sun? Nana didn't want to make any accusation, but this publication is from Nigeria, and maybe it's happening in other countries as well. So Nana, if that's okay, we can go around. I can post specific questions to different experts, and they can answer afterwards. So we just assign them and also.
Perfect.
So okay, thank you. So I think we've done well with that. We have one question for Professor Umberto here, which is, what happens with some of our old medicines that seem to be forgotten, and quinine is an interesting one. It would be nice to hear a little bit about the work, this work that you guys have done, and whether there's any room for quinine here, given limited drug resistance associated with it. That question has already been addressed. Also for Professor Umberto, these are research questions that you guys proposed several years back, and it would be nice just to hear from you whether there are still any key research questions, what you would propose for scientists going forward to focus on in the area of chemoprevention. We will skip this question. We already covered that, but there was the point that, in addition to water issues, you also have this issue of people crushing medicines. And Eddie Fakara, my colleagues, worked with MMV and did fantastic work demonstrating that dispersible coartem was as effective as work by Dr. Salim Abdullah. And the question here is whether this issue is important also for the medicines that are currently being used for chemoprevention, for either SMC or the other medicines. So this question is for any of our panelists. We have a question on post-discharge chemoprevention here. So again, anybody can answer that. And there the question really is, what really causes this extreme mortality after discharge? Unfortunately, Professor Professor Kamija Firi was unable to join us, but hopefully he will join us in the next masterclass. But here is the question: why are kids dying after hospital discharge? And this is work by Jean-Louis Ndiaye from Senegal in the past. And I think the key question here, and it was really, really nice to see the evidence that you guys have generated here. But when you expand this to 10 years, because in this case, you have this extension of SMC to kids aged 10 years. So in practice, how exactly would that play out, given that at least until recently, the guidelines for SMC were limited to a short period of time? So if you could just talk a little bit about the extension for that. And I think we would bring that to a close. We wanted to talk briefly about drug resistance. We've seen this evidence that drug resistance does not really increase with the extensive use of SMC. And here we would also want to hear comments from Jean-Louis and Ndiaye. And we have a review for that already demonstrated. And lastly, some comments, if possible, from Corinne, if Corinne is still with us, hopefully yes, and Dorothy, some comments here on the demand and supply, and I think Corinne already mentioned earlier some of these issues. But how do we ensure this going forward? Do we need to, be working more, encouraging more with the partnerships such as MMV Access Program? What do countries need to do going forward? And then lastly, we would like to hear final words from our NMC colleagues in Tanzania. So I think we can take them in whichever order, and you don't have to answer all the questions. So you can just answer one very quickly, and we proceed like that because we are drawing towards a close. And we're going to start with Umberto, and then move forward.
Yeah, thank you. I mean, I think you are very optimistic if you think we can answer all this question in 1 minute. But anyway, for quinine, yes. Yeah, just very quickly for quinine, it's a drug that exists, is used to treat severe malaria. Now, WHO recommends the use of artesunate, injectable artesunate for the treatment of severe malaria. And then, the treatment, a full ACT treatment once the patient is able to take oral treatment. So I think quinine is, I'm not sure even if quinine should be available, I think we should ensure that really artesunate injectable is available, and that also the full treatment is given. So in other words, artesunate injection plus at the end a full oral treatment with an ACT. In terms of IPTP, in terms of question, just to say, I mean, the question of what drug to use for IPTP is still open. And then there is a question. I just had a look at the question. The issue of P-Vivax, for example, which is seems to be not a huge problem for Africa, but P-Vivax, how you prevent P-Vivax infection in pregnancy. That's the other issue. I'm sorry, I have to go to another meeting. So thanks a lot for this. It was very interesting, and have a nice day. Bye-bye.
Thank you very much, Ubento.
Bye.
Jean-Louis?
Yes, thank you, Fedros. Thank you, you all for your very, very relevant question. What I can say is, I mean, since the WHO recommendation in 2012, the eligibility criteria for seasonality was more than 60% of rainfalls concentrated into 3 months and more than 60% of cases in 4 months. And the estimates of children to be covered by the SMC was 25 million. So 10 years after, you will realize that the last figure from 2021 is SMC has been implemented, it has covered 45 million children, meaning that the country are not really following those guidelines, meaning that country are seeing that the burden of malaria is more than what was previously planned or estimated. So that seems that now we just a couple of weeks ago, we just revised the WHO field implementation guide to be less restrictive. So allowing countries to really adapt the strategy into the epidemiology. So that's what happened since the beginning in Senegal when we saw that I mean, children from 5 to 10 years old were developing as much as clinical attacks compared to the others. And we found out there was also the burden of severe malaria in that target age groups. And other countries are also seeing that. I mean, the Gambia is planning to. So there's several pilots in Mali, in Burkina, in other countries. That's really the message. So each country should now see where is really the burden of severe cases and try to adapt the strategy. In the 45 million children covered in 2021, we see that many countries are not doing only 4 cycles. Some are doing 5. Those are doing 3 cycles. So we need to adapt to be more cost effective, of course, but also to really target your age group. That's where we need to optimize the delivery of seasonal malaria prevention. That's where the room we have to improve now is really how to count the number. The ideal start, I mean, Dorothy was saying that there's still more cases coming. Maybe the optimal start is not really defined in countries. Maybe the end, also the peak of the transmission is not also covered. So there's a lot of room to increase. The age range as well is another questions. So we are in the SMC Alliance. We are really supporting all countries, and hopefully maybe Tanzania will join us to help the country to identify really the SMC eligible area, the best target group, the best period to start, the best period to stop. And what we can see also is, since several surveys, resistance is not also a big deal. So I think SMC has some future coming, but we need to optimize it clearly, and also to evaluate the impact properly using very standardized methods to help the countries. Very briefly, that was a kind of summary I can add to the discussion. Thank you so much, Fedros.
Corinne?
Yeah, so first of all, thank you very much for inviting me. And this was really, it is an excellent platform to discuss. And, you know, those are really what we need and what is really helpful for countries as well as partners that are supporting countries to deploy all the innovative tools as well as the mixed intervention. So maybe to respond to your supply question, as I said earlier, there is no issue of supply. So there is at global level partners that are working together, supporting countries to have a clear plan and also help them to do quantification. Countries are quantifying all the needs. But the most important is, number one is the importance of data, as we say, use data to decide what are the best intervention. And we partners, we are here to support countries, either researchers to provide data, to do research. We see the NMCP like Tanzania, who are also implementing research to guide their policy. This is what is needed. And importantly, it's important also to, we are within a context of limited funding. So we can't do everything everywhere. It's, unfortunately, we have to make tough decisions. We have to decide and choose, prioritize the most impactful intervention for us to achieve our goal to end malaria. This is number one. Number two is in terms of the action that are being done for substandard drugs. On top of what David said, it's important to note that it's really important that we get regulatory authorities at country level to protect and then to make sure that the drugs that enter in the country are of quality and then are also standard, they are not substandard. This is number one. Number two, there is an important work that is being done at continental level. There is the AMA, which is also a regulatory body for Africa, where all countries, they are yet to sign. I know that there are 23 African countries that have signed. So they're going to harmonize all the regulatory mechanisms to get good drug, quality drugs. This includes malaria drugs as well as other health products. So this is number two. And then in terms of also drugs, I know that MMV is working with many partners to ensure that they get also dispersible tablets as well as formulation that are friendly for children. But for Africa, we need to also make sure that we discuss, we regulate the private sector. Private sector is where maybe 50% of our children, 50% of the malaria cases go to seek for treatment. So it's really important that a country, we support country national system to regulate all the drugs that are entering, and as well as at global level, what we are doing in collaboration with all the key malaria partners. Thank you so much.
Thank you so much. Dorothy?
Yes, thank you so much. It's been very interesting discussions. I've learned a lot. And I just wanted to add, after my sister Corinne, to say, I want to talk about the last mile delivery, because sometimes you can have drugs in the country, but they're not getting to the people. And that's why we have problems with supply chains. And each time we do a common prevention program, we are reminded of that we need investments in supply chain management. And because where the drugs are not there, then there is no program. You can have everything you want, train people, but if you don't have the drug to give the children or the pregnant women, then you have failed. And that's why we are having low coverages everywhere. So we need to optimize our health system, our delivery systems, by giving the right tools and even improving on logistics information management. Because sometimes people do not even know that these stocks out there and the drugs are lying somewhere. And usually, since it's free, the drugs are free, the accountability is a bit lower. So that is one aspect. But in addition to the existence of global supplies, it's also important for the countries to get these drugs in time because the lead times have increased. So it's become more and more important that we do forecasts. So if Tanzania needs a drug in 2024, for example, it is now that they have to really start thinking on what are the drugs and start informing the partners so that the requests are put in time. If not, we'll have gaps in our supply chain, and that will affect our results and our performance and our coverage. So that's just the additional thing I wanted to ask in terms of supply chain. And since we are over time, I will stop there.
Thank you, Dorothy.
Thank you.
Done, right? With that.
Yeah, I think I would like to invite our colleagues from
Tanzania
Tanzania to have the last word. First of all, to thank them also for agreeing to share published data with us during the presentation. But also, I hope that our Tanzanian colleagues also received a reasonable level of comments from our global experts, and I hope that they find this useful, and we encourage this kind of partnership. Hopefully we will have more discussions like this. I hope that most people have learned a lot from the Tanzania presentations, and we would like to give them an opportunity so that they can provide their final words now before we close. So our colleagues from Tanzania, please, either one or two of you.
Okay, thank you so much, Fedros and the entire team for participation. Yeah, the discussion is very good. We learned a lot. Sorry, Fedros, my computer has a problem. So I'm using another computer. I'm Dr. Lusasi. Yes. So we thank you so much and the entire team for good discussion. We learned a lot from scientists. We learned a lot from different experience from different countries. So we say thank you so much. Tanzania, malaria in Tanzania is heterogeneous. So this preventive therapy is a new tool to us. And they will not replace or compromise other co-intervention. So to us, we think we shall do modeling for impact in the cost benefit. And then more we do, we analyze the implementation issue further in the country to see how will it be in the future, the issue of scale up. But again, we submit this information to the higher management in the Ministry of Health. Eventual, if possible, to submit again these issues to Global Fund, the new cycle funding issues. So thank you so much.
Thank you so much, Dr. Lusasi and your team. And now I would like to hand it back to my excellent co-host, Nana Alba-Williams. We didn't mention earlier that our former co-host, Dr. Sheila Ogoma, is taking leave from the program, but hopefully we'll have her back. And Nana and myself will continue co-hosting. And of course, if there's anybody in the audience who wishes to co-host with us, do let us know. But Nana, please, you're going to have the final word and close the session for us as well. Thank you so much.
Thank you. We'll have the final word after me. Thank you very much to everybody, especially to our experts. All of you from Tanzania, thank you so much for such a succinct presentation and for gathering the information that you've shared to us and to the world, I would say. Thank you so much for the David for all the insight from the work that was done at WHO. Also, Jean-Louis, with what you're bringing from the SMC consortium as well. And now we have the Tanzanians who are going to hopefully join as well, and other folks around. And also to Dorothy with what you bring from country, and now with the multi-sectorial background that you are also adding at WHO Afro now. Also to Corinne Karima. Umberto, who's gone off now, but thank you so much to all of you. There are many other experts you could have brought on as well, but well, there are only so many we can have at a time. So many more other classes will be coming up. And thank you very much, Fredros. And
the chat was terrific today. Thank you all for the participation.
Have a good Merry Christmas and Merry other religious celebrations or traditional celebrations as well for the holidays.
Best wishes. Bye.
Bye.
Merry Christmas, everybody. NMCP team now are visible. So
Thank you so much.
thank you guys for your time today.
Thank you.
Derek, it's nice to see you, my friend. Thank you guys. Asanteni sana.
Bye.
Bye. And we will share the recording to those who want.
Bye and thank you.
Bye bye. Thank you all. Thank you. Thank you all. Derek, get well soon, my friend. You're muted, but I can see you. All the best. Yeah.
Yeah, I'm fine.
Excellent. Excellent. Get well soon.
Good. Good to see you, Fred.
Good to see everybody. Good to see you.
Yeah. Yeah. Ciao.
Ciao. Muito obrigado. Muchísimo obrigado.
How do I get off?